right. Well, thank you for showing up to this afternoon session, and I appreciate your time today. So, as most of you are probably aware, pathophysiology and the hemodynamics of cardiac arrest is a huge topic with an entire body of literature and book chapters dedicated to it. So I'm going to jump right in. I have no pertinent disclosures, and I'm going to start with what you need to know. So there's heterogeneity in the pathophysiology and hemodynamics of cardiac arrest. And while this talk is not about patient selection for ECPR or predicting outcomes in patients that have cardiac arrest, I encourage you to think about the rest of this talk in that context. And that's in so much as these are the building blocks with which you will think about placing patients on a resource-intensive intervention like ECPR. So on this slide, there's nothing that you guys haven't seen before, but I do want to point out a few of the key nuances here, and that is that cardiac arrest and respiratory arrest by nature are two distinct entities, and while one inevitably leads to the other, respiratory arrest comes in a couple of different flavors, and the prodrome that's usually associated with it includes ongoing hypoxia, ischemia to tissue, and oftentimes injury prior to the actual cardiac cessation. Similarly, cardiac arrest has a few different presenting rhythms, and I've listed here for you some of their associated etiologies. You guys know this, have seen this before, but I'd encourage you to think about those that are more reversible than others. And I think that's best illustrated if you think about a couple of cases. So if you take a 57-year-old gentleman, for example, who was in a motor vehicle accident, has multiple limb trauma, open head injury, and is in PA arrest when the EMS arrive, brought into the emergency room, found to have massive hemoperitoneum, still in PEA. And you compare that to a similarly aged 57-year-old gentleman who's on his Peloton bike, is at the gym, clutches his chest, falls over, found to be in VFib arrest when the EMS arrive, multiple shocks, and then taken to the ER, still in refractory arrest. You know, if you're familiar with the out-of-hospital cardiac refractory ventricular fibrillation data, you know that this man likely has underlying coronary disease, which is a highly reversible etiology and may be a better candidate for ECPR. So I'm actually going to switch gears now totally because I also have the obligation to talk about the hemodynamics of cardiac arrest. And so I'm going to talk about CPR and what happens during it. Most of you guys are familiar with the basics of ACLS, and we're going to dig a little bit more into the data to understand the hemodynamics. So when you think about CPR, there's two phases here, a compression and a relaxation phase. During compression, there's two schools of thought, that you are directly compressing the left ventricle, expelling blood out of the LV into the arterial system, and that you're also increasing the intrathoracic pressures to expel that blood. During the relaxation phase, it's in direct contrast to normal respiration, which creates negative pressure. This is a passive filling of the right ventricular side, which also, in theory, leads to increased vascular congestion and intracranial pressure. So high-quality CPR is defined by rate, depth, and recoil. This is some of the data for chest compressions and the compression depth that leads to improved outcomes. Similarly, the data for chest recoil is shown here. On the right-hand side, you can see that incomplete recoil, or leaning on the chest wall, leads to increased intrathoracic pressure. And for reasons we'll talk about later, that increased intrathoracic pressure leads to rise in intracranial pressure. So this is data from an animal model in which a piston is used to compress the chest wall, and it's set to either recoil at 100 or 75%. Let's see if I can... Yeah, at 100 or 75%. On the right-hand side, you see here that in blue are the aortic pressures generated with that CPR, and red, the ICP pressures, and the difference between these two is the cerebral perfusion that's marked in black. When you compare the 100% recoil with this cerebral perfusion pressure to 75% recoil, there's a significant decrease in cerebral perfusion pressures, suggesting that incomplete recoil results in decreased cerebral perfusion pressure. So with these parameters in mind, we've known for a long time how to perform high-quality CPR, but that just doesn't happen. In about 45% of patients, we get all three of these correct. And this is in 9,000 patients across the United States. And so this is actually one important point of this talk, is that working with our EMS and training and retraining and exercising to make sure that we have the highest quality CPR brings to our ERs, those patients will be the highest and best protoplasm for potential potentially CPR. There are multiple tools on the market that help give real-time feedback to improve that quality of these parameters. So despite this, there's patients that never achieve ROSC, either rearrest or have neurologic injury. And what do we do about that? So this AHA consensus statement identified the goal of CPR as restoration of adequate coronary and cerebral blood flow. And it goes without saying that there's several factors that make sense of what we should pay attention to achieve this goal. One being cardiac output. Now, cardiac output's very difficult to measure in real time if somebody's arresting, but end-tidal CO2 is a reasonable surrogate marker. And I say that tongue-in-cheek, recognizing that end-tidal CO2 is highly variable, dependent on ventilation or lack thereof. So if you're not ventilating a patient, if CO2's 100, your end-tidal is likely going to be higher. Similar to cardiac output, cerebral perfusion can't be measured in real time during a cardiac arrest, and unfortunately there aren't many good surrogate measures. And then coronary perfusion is necessary if you're intending to achieve ROSC, and so diastolic blood pressure is a reasonable parameter to look at as a surrogate for coronary perfusion. So if these things matter with your goal of resuscitating patients, we should review the shortcomings of CPR in achieving those. So there's a lot of research going on in several of these areas, and one of which is location of compressions as it pertains to cardiac output. So this is just one paper that looks at the AMC, or area of maximal compression, as it pertains to the aortic valve. And you can see on the right-hand side of the screen, the right-hand side of the screen, that the positive numbers are compressions over the left ventricle and associated with higher stroke volumes. As we all know, stroke volume times the heart rate, or in this case, the compression rate, is directly proportional to the cardiac output. Interestingly, though, if we all follow the ACLS guideline of pricing our compressions over the mid-nipple line, only about 20% of patients will actually have the LV directly in that anatomic position, meaning that about 80% of our patients are not achieving, or potentially not achieving, maximal cardiac output from that position. So what I'm telling you is that the location of the compressions may not be good enough. And if you combine this with this difficult to achieve rate, depth, and recoil, among other factors that I just don't have time to review in the 8 minutes I was given, we're only achieving about 20 to 30% of ideal cardiac output in these patients, and this is with perfect CPR. Okay, cerebral perfusion, really tough topic to talk about and add in here, so I'm going to do my very best. As a non-neurologist, I will do my 1-minute spiel here, which is cerebral perfusion is your mean arterial pressure minus your intracranial pressure. And in normal people with normal blood pressure, we have autoregulation that maintains a normal blood flow to the brain. When your MAP drops below 50 or so, which happens in cardiac arrest, there's a loss of, I am really bad with this clicker. There's a loss of the cerebral autoregulation, and there's passive collapse of the arteries, making any increase in ICP potentially deleterious to cerebral perfusion. So we've known for a long time that in animal models and now in humans that there is increase in intrathoracic pressures that are directly transmitted into the brain through the arterial and venous systems, and that is only exacerbated by positive pressure ventilation that also increases intrathoracic pressures. So this makes a bad situation worse, where we have patients that have already low MAPs, and then we increase their ICP through CPR. Reducing their cerebral perfusion. Again, we don't have time to go into this in depth, but the intrathoracic pressure regulation has been looked at in great detail, and there's multiple different devices on the market, including the ITD and ACD, which are meant to reduce the flow of air into the chest during decompressive phase of CPR and apply negative pressure to the chest wall during the decompressive phase, respectively. What this does is allow the RV to fill, and with the RV filling, you have increased cardiac output, presumably increased MAP, and then venous congestion is decreased with a decrease in the ICP. We don't have time to talk about hyperventilation, so I'm going to skip that. And what I want to summarize here is that regardless of whether you have CPR, a standard CPR, or this is our data from the University of Minnesota, ECPR, the longer that you receive CPR, the less likely you are to have neurologically favorable outcomes. And what that means to me is that even with the highest quality CPR, we are not achieving adequate cerebral blood perfusion. So I've talked to you about cardiac output and cerebral perfusion. I'm going to take one last minute to talk about the coronary perfusion pressures that happen during CPR. Now, we all know that coronary perfusion is during diastole, during normal rhythms. This is true also during CPR. And diastolic pressure, coronary perfusion can be measured by diastolic pressure minus the right atrial pressure. It's also known that in CPR, those that have the highest coronary perfusion pressures are more likely to achieve ROSC, and this is no surprise. You need flow down your coronaries to achieve normal rhythm. So what I've shown you now is that CPR is a low flow state with high intracranial pressures and low coronary perfusion. And I'm going to take one last minute to talk about how does ECMO play into this, since this is an ECPR lecture. So things that matter. We already talked about cardiac output, and as that pertains to our ECMO, this is some of my colleagues, Jason Bartas and Dr. Dimitri Yiannopoulos, and they're placing a patient on ECMO. Here's the Lucas device. And what we see is almost within seconds to minutes, we have up to 4 and 5 liters of flow. So cardiac output's immediately addressed. Well, what about cerebral perfusion? And the data here is fairly limited, but maybe. And so I'm going to make a big jump and just reference the ARREST trial where we had up to 40% neurologically favorable survival. And what I mean by that is that these patients, the cerebral metabolic needs were clearly met once these patients were placed on ECMO if they had this degree of neurologically favorable outcomes. And then coronary perfusion. Well, similarly, maybe. We don't have a lot of data. There's ongoing research in this area, but I'd like to make one last mental jump with us. So if we think about the probability of achieving ROSC as the duration of CPR lengthens, so this was a study in British Columbia of 2,500 patients, and you can see that the longer you're receiving CPR, the less likely to achieve ROSC. And this is probably many, many factors. Terrible metabolic derangements, but also possibly some contribution from poor coronary perfusion. This is some unpublished data of ours, and I want to just highlight a few things here. There are those with coronary obstructive disease and non-obstructive disease, and if you look at this area here in the red box, this is the patients that we placed on ECMO, and within 2 to 3 minutes and 2 to 3 shocks, so very immediately post cannulation with no other interventions, 30% in both of those groups achieved a organized rhythm. So this suggests that doing nothing other than providing flow, presumably to the coronaries, allowed us to develop an organized rhythm. So take-home points, there's heterogeneity in cardiac arrest, pathophysiology, and hemodynamics. It's these differences among many, many others that are critical in patient selection. And ECMO likely provides better hemodynamics than traditional ECPR. And while it's not the panacea for all cardiac arrest types, clearly there are some people that will likely benefit.
Thank you, Simon. It's my great pleasure and honor to be here after COVID. I had a talk on a similar topic pre-COVID, and I promised that maybe next time I'll show some results, so that's the time. And thanks, organizers, to provide me with 8 minutes to summarize what I did for past 10 years. So I'll try to do it fast. So we have heard yesterday it's difficult with the evidence for VV-ECMO in ARDS. We have no evidence for VV-ECMO in cardiogenic shock, basically no randomized trial. So what about the ECPR? CPR, as you know, is just to put a patient who is basically dead or in cardiac arrest, put an ECMO and hope that some of those patients will survive. That's true. And we use VV-ECMO, and there's some places where they use different devices for ECPR, but we basically use VV-ECMO. And in that case, you can rescue patients with such nasty ECGs, or maybe this one, also pretty nasty ECG, and this is the lady who has been resuscitated for 72 minutes, and I might show you a lot of pictures like that, but I also could show you a lot of pictures of those who didn't survive and who didn't make it, but that's the life. So we have heard from a colleague of Dimitri's that this was the first randomized trial in a ECPR setting. Small trial, stopped after 30 patients, and as you know, 6 patients in the invasive arm survived well with a favorable neurological outcome, and nobody survived in the other. And at the end of my talk, I'll compare the trials. So that's where we were 2 years ago. This year we published our trial, we call it BREAKOUT, the hospital cardiac arrest trial, was actually little more complicated trial. We compared bundle of interventions, which was intra-RS transport, extracorporeal CPR, immediate invasive assessment and treatment, and we assessed it for the neuro outcome after half a year, so for a very hard endpoint. As you know, in cardiac arrest, and I'm talking about the refractory cardiac arrest, it has a poor outcome. ECPR is promising in this setting. However, benefit of the ECPR still remains kind of uncertain. So as I said, we compare this bundle to the standard ACLS on-site. We enrolled patients of 18 to 65 years of age with cardiac arrest of presumed cardiac cause, and we randomized those patients to invasive versus standard arm during ongoing CPR on the scene. So it was done from the March 2013 to October 2020, so the study took almost 8 years and was prematurely stopped by DSMB. So how it looked like during the study, the patients were randomized during active chest compressions to avoid any bias. As you see, we enrolled witnessed out-of-hospital cardiac arrest, and the other inclusion criteria was minimum of 5 minutes of ACLS. In comparison to arrest, we enrolled all rhythms. This trial was designed 12 years ago, so at that time we didn't have too much information on how patients do in other rhythms than we have, so we enrolled both PEAs and asystoles. And the patient had to remain unconscious, and we looked for ECLS and ICU bed availability. We excluded just patients of non-cardiac cause and unwitnessed collapse, and those who were within the ROSC within first 5 minutes, so we didn't include patients who got early ROSC. As you can see, after randomization to the invasive arm, the patients were transported under ongoing CPR, a mechanical CPR provided by Lucas. If they got a ROSC en route or just immediately after admission, they were examined invasively in the cath lab, so we did everything in the cath lab, similar to Minneapolis. If they didn't have a ROSC, we put them on ECMO and then proceeded with the further invasive evaluation. In the standard arm, we continued CPR on-site, and if the patient got ROSC, he went to the invasive center, again to the cath lab, and the invasive assessment was encouraged even in the invasive arm. If the patient didn't get a ROSC, he was pronounced dead on site. The randomization was made by a web-based secured randomization system, which was available 24 hours per day on the cellular phone or on a computer. And we consented the patient's legal representatives for agreement to participate in the study and providing data. And in patients who regained consciousness, we got a consent from themselves. We used the frequentist analysis, strict intention to treat, and the crossover in the arms was defined by the amendment, but the crossover was low, below 8% in both arms. So this is the study flow. And during the study period in Prague, which has a population of 1.25 million people, and the advantage is that we do have one emergency service for the whole Prague and one dispatch center for the whole Prague. So it's very suitable for communication and collaboration. We did have 4,300 or 4,345 cardiac arrests altogether. 358 were patients without return of spontaneous circulation who were assessed for inclusion. 94 were excluded because of the age and physician decision not to enroll, referred to other institutions. Only in 4 cases, actually, we didn't have a capacity to accept the patient during those 8 years of the study, and at the end, 264 were randomized. It's 6%, so this aligns pretty well with other studies showing that you should select patients for ECPR, like about 6 to 8% of all out-of-hospital cardiac arrest patients. So just briefly, with the main baseline characteristics, so we had 60% of ventricular fibrillation shock algorithms in study, about 20 and 20% of asystoles and pulseless electrical activities. We had a very high percentage of bystander CPR, almost everybody, and I have to disclose that in Prague, the baseline bystander CPR rate is 80%, similar to other Scandinavian countries and Netherlands, for example. We had 80% patients receiving telephone-assisted bystander CPR, extremely important intervention, and time to randomization on scene was 25 minutes, overall 24 in the invasive and 26 in the standard arm. So basically, it was 10 minutes to reach the scene, 15 minutes to perform ACLS, and after 25 minutes of unsuccessful ACLS in terms of achieving ROSC, patients were randomized. This is the main message of the trial. What I think is that the time of CPR, which has been defined as a time to death, time to ROSC, or ECLS, was median of 58 minutes in the invasive strategy arm and 46 minutes in the standard arm. So we really pick up truly refractory cases, and probably many of us would stop CPR before resuscitating for 46 minutes and even 58 minutes. So this is, when we interpret the data in this context, this is the most important parameter of the study. Concerning ROSC on admission, there's been still, the patients have been loaded into the car in the invasive arm while being resuscitated for ongoing cardiac arrest, still en route or immediately after admission to hospital. 27% in the invasive arm achieved ROSC and 44% achieved ROSC in the standard arm. And concerning cannulation and ECLS, you see 66% at the end received ECLS in this invasive strategy arm. 10 patients received ECLS in the standard arm. Those were those who were crossed over from standard to invasive, but evaluated as a standard. And we had 12 minutes cannulation time on average, and we counted the cannulation time from crossing the door of the cath lab to running ECMO. And this is the main results, which need some explanation. Our primary outcome was survival with minimal or no neurological impairment at 180 days, so hard outcome. 31.5% of our patients survived and reached the outcome in the invasive strategy arm, and 22% in the standard strategy arm. What happened here is that we didn't prove actually the difference in primary outcome. However, when we designed the study 12 years ago, we presumed that we were going to have a 10% of survival in the standard strategy arm. So what happened by implementing invasive strategy in those years, we increased much the survival even in the standard arm, and therefore we were very close to statistical difference. We did prove a difference in the neurological outcome, which was neurological recovery at 30 days, which was significantly better in favor of the invasive strategy arm. There was no difference in the cardiac recovery, despite the fact that numerically it looked better for the invasive arm. If you look at a subgroup analysis, the most important message is subgroup analysis of the shockable versus non-shockable rhythms. If you look at the outcome of shockables in the invasive strategy arm, the survival was 48.6%, so almost half of the patients in ventricular fibrillation survived until 180 days with normal neurological outcome. Survival related to time of CPR is also an interesting subgroup. So if you look, the all benefit of ECPR actually occurred in those patients who have been resuscitated more than 45 minutes. In those patients resuscitated below 30 minutes and 30 to 45 minutes, there was no difference, which can be also interpreted that we didn't harm those patients by implementing the intra-arrest transport. And if you look at this group, 6 patients survived in the standard strategy arm. However, 4 of those 6 survivors were actually those who crossed over. So they were treated by ECMO, but evaluated as a standard by the intention to treat analysis. Still, this difference was significant. And if we imagine that we would put 4 patients here treated by invasive strategy arm, the difference would be even more different. If we compare available 2 trials, so RS trial and our trial from Prague, you see pretty similar. We had almost 10 times more patients In the invasive arm, 124 versus 15. Similar age, very similar percentage of males, very similar percentage of bystander CPR. We had all rhythms, 60% was VF. All patients in arrest were in VF. We randomized on scene versus randomized on the admission to ER. So this is completely different trials. Our trial compared the strategy when you have a patient in the field with refractory cardiac arrest, whether to go or not, and when to go. The arrest trial has shown that if you accept a patient to hospital after 50 minutes of unsuccessful CPR and you don't put a patient on ECMO, you basically have no chance for survival. And concerning survival in those two trials, you see 31.5% versus 43. However, if we look at a subgroup of shockable rhythms, 49 and 43, very comparable. So we have shown together that for VF patients, they have a good chance for survival in ECPR groups. So let me conclude that there are some clinical consequences what we have seen, that not ECLS alone, that's just a device, but a comprehensive approach, including ECLS, may have an impact on logistics for out-of-hospital cardiac arrest. And our trial had to be interpreted as a negative trial in terms of primary outcome difference, despite the fact it was borderline, but has many positive findings, actually. Very high percentage of bystander CPR and dispatch CPR, 2 times higher survival in the standard strategy arm than expected. Excellent survival for patients overall, 27 overall survival, considering all the patients have been resuscitated more than 45 minutes. And there was a signal of benefit in subgroups. Crossovers survived in 45%. Patients with cardiac arrest over 45 minutes purely benefited from invasive approach. And there was almost 50% survival in the shockable rhythms. And in the ECPR group, so those patients who were treated at the end with ECMO, there was 22.5% survival, and their cardiac arrest lasted 61 to 62 minutes. So let me conclude that ECPR should become a standard of care for selected patients with refractory cardiac arrest, and I think it's time to change the practice. Thank you.
Well, it's wonderful to be here. I very much appreciate the opportunity to speak on behalf of a large group of people. We come from Melbourne, Australia. That's why I sound funny. And it's a great honour to represent some of the work that's been done by our group. This won't be a pressured talk. There's not a lot of data that we're going to have to trawl through, but hopefully we can think together on some important topics regarding ECPR. And before I start, I just want to say that's the first time I've seen Jan present his results like that, and that is an outstanding amount of work. It's completely different to what I'm presenting, and it stands in a whole nother level. So let's get started. In terms of disclosures, I have no financial conflicts of interest to declare, but I am paid to do 2 jobs. One is as a lead in a hospital, and one as a statewide ECMO coordinator for a whole region, which is an important disclosure. So if we start with the problem of cardiac arrest, this is something I'd like you to remember, is that sudden cardiac death contributes to a huge amount of life years lost, much larger than most people realise. So of all cardiac deaths in men, about half of it is lost to sudden cardiac arrest. And it's about 2 million years for men in the US each year. And it exceeds all other individual causes of death, sudden cardiac death. And so it wouldn't be beyond us to try and come up with a mechanical way of re-establishing circulation in that time, and we come to ECPR. So some of these slides were from the last presentation, and we're going to carry them a little bit forward. So the topic of this talk is about, developing systems in hospitals to do this work. And I don't have a lot to say on that subject. I mean, we invented sort of roll cards 10 years ago, and they're freely available online at ecmo.icu, which has all the guidelines. It's freely accessible if you want to. And you obviously need training, teamwork and coordination to get 11 people to do their jobs at the same time, which is usually possible, except inside a cath lab where nothing seems possible. And this slide's as old as the auto pulse, which is on the mannequin, and this was during our development phase of our protocol. I'm sure all of you have done similar things like that in the past and accredited people to do the job in your hospital. That's how we've done that. And that's sort of been done for a long time, and I'm sure many of you are doing the same sorts of things. I don't have too much to say for it. What I'd like to talk a bit about is the impact of when we do that. So over 8 years of rolling out that program, there were 14 people who left hospital well after a sustained cardiac arrest. So 8 years is about as long as Jan took to do his trial. And it's a long time, so you don't produce a lot of survivors in that time, from about 50 cases. Now, they're all fantastic survivors. In the Paris study that published over nearly 7 years, there was 44 survivors from over 500 ECPR cases. In the Prague study we had a similar timeline, 90 months, 39 survivors. In Aroka, which was another trial, randomised people to ECPR in Michigan, I think it was, there was no survivors in that trial. I can't remember how long it went for. It's not important. And in the arrest trial, as we heard, 7 over 10 months or so. Now, and then the wider application of the extension of that trial to more sites led to much higher rates. But what I'd like to compare those numbers to is just in the state of Victoria where we live, a population of 6 million people, there are 200 survivors every year from VF arrest who are EMS attended. And there are 400 a year every year. So in comparison to what we're doing with ECPR, those numbers are tiny compared to that. Which brings me to my thoughts on ECPR in general, which are the effectiveness of an ECPR program is very site-specific and it's not a generalisable thing. It depends on lots of things. ECPR can't currently change the outcomes of sudden cardiac death. ECPR process should not override the delivery of optimal conventional cardiac resuscitation. And I think the really big point that was not glossed over by Jan but deserves re-emphasising is that the big difference was in the control arm survival in arrest, and that time could possibly be associated with time at scene, providing better outcomes for that group. So optimal conventional CPR is really important. And so why do we do this? We do this because of our 18 survivors, we remember them by name. They are extraordinary stories, and being able to help these people is a good thing to do. And the next point I'd like to bring up here, the relationship between utilisation rate and survival rate. So we've known for a long time, and Jan just presented more evidence to support this, is that if you want survivors from ECPR, you need those inclusion criteria on the right. And that survival rates are largely dependent on who you put on. So the out-of-hospital cardiac arrest target population is actually about 5%. So that's our true denominator for ECPR of all cardiac arrests. It's about 5% who don't get ROSC with standard resuscitation at that rate. And so this dawned on me, thanks to help from one of my colleagues at work, Arnie Deal, is that your utilisation rate and your survival rate are actually linked in this way. You can put young people on with unwitnessed asystolic arrests and you'll have more utilisation and lower survival rate. So if you break your inclusion criteria rules, you get more cases but less survival. If you tighten your inclusion criteria, so it has to be Mr. Perfect, you know, everything lines up, you don't wind up doing much ECPR. And the other associations I bring there is that the more you do, the more you learn about it, the more you get good at it, and the more you cost the system. So in terms of performance now, what I think is a good performing system is if you have 5%, if you can get to those 5% of people, that's really important, and that you can commence ECMO in a timely way to those 5%. And then there's plenty of talks at this conference about what you do after that, which is the delivery of safe ECMO care and all the ancillary care that goes with this patient group, and access to long-term cardiac support options, which are really important for survival in this group. A lot of these people don't recover their cardiac function. So this is how that all ties in. If you can get all those other things, you get a stronger relationship there. So what I'd like to talk about now is the elephant in the room, which is high-performing ECPR programs really depend on us reaching that 5% of patients much more than we currently do. It's not, in my view, about getting better at treating that minuscule population we get our hands on. So doing an even better job at that less than 1% that we see will not be as effective as getting to more people. And I think the main barrier is being able to establish ECMO in different contexts, in different places, by different staff. So what I'm going to do for the rest of the talk is just run through this idea that because ECPR is not completely straightforward and relatively few patients benefit who are delivered to hospital and relatively few staff are available to do it, you know, how we provide ECPR services to improve the reach of the support and who should provide it. So I think the expert model of people who do it all the time is very limited in its application. And I'm wondering how far we can go in the area of extending it to the population that needs it. Rizan El-Jafri is a materials engineer that's worked in the department and done a PhD on training for this very purpose. That's not her photo, but that's a QR code that will take you to her if you want any of the materials that we're going to show just next. And so they're all the steps that you need to learn. And one of the interesting things is watching Rizan over the course of her PhD as a materials engineer become an expert cannulator, actually. That couldn't help noticing that happening. And so she's developed some tissue mimicking materials which are very useful in training people. So this isn't designed to simulate the human experience. We can make task trainers as difficult or as easy as you need them to be, and you can play on them outside your work environment to develop skills. As well as that, she's developed a model that you can practice the whole routine on. And it's not done yet. There are more and more of these educational quantum leaps coming, particularly in the world of virtual reality, where you can have the patient in the bed with the monitor in your living room. And you can mimic scenarios over and over with that way. So in terms, my final comment is that ECPR, unlike other forms of ECMO, might not be about the experts at all. They do a great job, but they get access to too few patients. It may be about extending the scope to reach more of our cardiac arrest patients that need it. How far can these new training technologies take us? I'm not exactly sure. It is the future, as I see it. And that's it. Thank you very much.
Good afternoon, everybody. What an amazing set of lectures so far. I just want to echo my admiration for you, Jan, and for the study that you've done. And I hope that we actually get to collaborate on what I'm about to talk about. So I'm going to be a little bit narrow in focus given the time constraints and tell you mostly about what we have been working on in our lab group related to ECPR and neurologic protection. I have no important disclosures related to this presentation. So as we all know and have heard very eloquently stated today, ECPR represents an ischemic injury. The duration of CPR and the diminution in cardiac output related to CPR results in significant organ ischemia that's global. It affects all organs and is a major contributor to mortality, even in the setting of ECPR. And we do a lot to try to minimize this ischemic injury, including minimizing CPR time, being efficient with our cannulation, performing high-quality CPR with minimal interruptions. And in the setting of congenital heart disease, we have to think about other things like runoff lesions and things like that I won't belabor today. And we prevent fever, and that's really it. The rest is really up to the body to heal itself. Can we do anything more to treat the ischemic injury itself? That's really the question I want to talk about. So our research group is a translational research lab. We're trying to create new therapies related to oxygen delivery and ischemia reperfusion injury. One thing that I'll mention just in passing is that we're creating a way to inject oxygen gas directly into the bloodstream that may be useful in situations of airway occlusion. This is data from a pig asphyxial cardiac arrest model, and I put it here only to mention that 1 approach to this is to decrease the oxygen deficit that occurs during a cardiac arrest. And that's what we are showing here. And this is still preliminary, but will be presented at the AHA this year. And this change in oxygen delivery does impact neurologic outcomes. I'm going to spend the rest of our time talking about hydrogen, which is just hydrogen gas, 2 protons, as a way to treat ischemia reperfusion injury. So as you all know, ischemia reperfusion injury stimulates an incredible cascade of events on a biological and molecular level that results in oxygen free radical formation. And hydrogen is known to be extremely reactive with oxygen. In fact, and it forms water. And in fact, the name hydrogen is hydro, meaning water, and gen, hydrogen, water generating. So this has been recognized for a very, very, very long time, and was really brought to the forefront of my mind and many others by this paper in Nature Medicine, in which a group from Japan treated mice that had middle cerebral artery occlusion with hydrogen, primarily during, primarily during the reperfusion period, and showed that there was a significant decrease in the ischemic injury that occurred with hydrogen post-treatment. So my interest was piqued, and I decided to try to investigate this. So we began with a preclinical trial that was funded by the American Heart Association. And what we did was we took swine who were neonatal swine, created a period of warm circulatory arrest on bypass that was 25 degrees, created 75 minutes of circulatory arrest. This was a significant injury to these pigs. And then we rewarmed them and tried to survive them out for 72 hours, where we got a terminal brain MRI and histopathology. What we found was that the neurologic deficit, so a higher number, I'm really also not good at this. The neurologic deficit score, so a higher number here is worse. 500 is essentially brain dead. And the control group fared much worse, statistically worse than the hydrogen-treated group over the 3 days. Both groups got a little bit better over time. GFAP is essentially a troponin for the brain, if you will, and it's a short-term marker. That was better at 60 minutes in the hydrogen-treated group. We also got brain MRIs, and what you're seeing here is a volumetric depiction of the median brain injury between surviving animals in both groups. There were 8 swine in each group, I should mention. And what you see here is that the hydrogen-treated group was significantly less injured by brain MRI compared to the control group. We also looked at histopathology and showed significant improvements with hydrogen treatment in the frontal and parietal cortex. So we were encouraged by this. We were surprised to also see an improvement in renal injury. The creatinine was significantly better in the hydrogen-treated arm. So we had a lot of positive endpoints with only 8 animals in each group. And of course, this is experimental, it's well-controlled, etc. But we were encouraged nonetheless. We then did a very brief study in 25 mice showing that mice tolerate breathing 2% hydrogen quite well. And so then we went to the FDA and said, we think we're ready to try this in humans. There had been several other studies not in the US and not FDA regulated. This was the first FDA regulated trial of hydrogen. We treated 8 adults with hydrogen. They were healthy adults, just to understand its safety and tolerability. And it was remarkably unremarkable. So there were no significant changes in vital signs, no change in any labs that we measured, including coagulation, no change in spirometry, no symptoms associated with hydrogen treatment. So now I'm pleased to say that we have been funded by the NHLBI to perform a randomized controlled trial which will establish the feasibility and safety of hydrogen in ECPR. So we plan to enroll 53 patients between 2 centers, Boston and Texas Children's, in a 3-to-2 ratio. I'm excited to talk to you, Jan, about some of the logistics of your trial. in short, we're intending to randomize at the time of chest compression, and the decision to cannulate for ECMO. These will be in patients who have congenital heart disease. So this will be an inpatient trial. They won't be blinded. I'm going to show you a little bit of some of the logistics here. So as we showed in our animal study, we're planning to get pre-mixed hydrogen mixture. So this is a tank here of hydrogen with 2% hydrogen with 98% oxygen. This is 2% hydrogen with 21% oxygen, so essentially air. And we showed before and are proving to the FDA that we can pump these two tanks directly into a standard mechanical ventilator or anesthesia machine without any perturbation in its function, including volume measurements, pressure measurements, and FiO2 measurements. It functions just as normal. And we'll do the same thing with the ECMO sweep gases. So we will essentially perfuse all gases that exchange with the plasma through both the ECMO membrane and the lungs with hydrogen. That'll take place for 72 hours, and we will study primarily the feasibility of this approach, the fraction of hours that we're able to deliver hydrogen successfully, and then we'll also look at safety endpoints, which are really hydrogen attributable AEs that'll be adjudicated by an external committee that'll be blinded to treatment allocation. We're also, of course, going to look at efficacy endpoints, because what I really want to do is partner with Jan and others of you to do both an in-hospital and out-of-hospital ECPR trial. So we're going to look for power calculation reasons at survival to hospital discharge and FSS out to 6 months, other markers of ischemic injury, and then we're also, maybe just for fun, going to do point-of-care MRI using a system called Hyperfine in these patients to see if the signal there is significant. So in summary, hydrogen appears to decrease ischemia reperfusion injury. I did not pay at all the respect that I should to the many other investigators that are in this area who have done good work in preclinical models of hydrogen. It's been very well studied, and it appears to decrease ischemia reperfusion injury in many settings. Preclinical safety profile as well as in healthy adults appears to be favorable, and so we're planning this trial and following on with a larger efficacy trial. Thanks so much.
Good afternoon, everybody. My name is Karol Muri. I'm a heart surgeon at Baptist Health, Little Rock, Arkansas, and I will be debating Dr. Jonathan Haft on course of action in post-cardiotomy arrest, ECPR versus opening the chest. Is there a gold standard? The only disclosure I have that I think that I sound even funnier than Dr. Pellegrino, so I apologize for it. ELSA committee wanted to trick you and asking that question the way they did, because what they're really asking is, what do we do in post-cardiotomy arrest? Do we plan for emergent sternotomy and surgery, or do we resuscitate the patient? If we ask this question that way, the answer becomes a little more obvious. But let's get back to the beginning. So is there anything unique about post-cardiotomy arrest? Yes and no. So it is a cardiac arrest, and BLS and ACLS protocols obviously apply. But the unique fact is that it is predominantly caused by 3 factors: bleeding, rhythm problems, and tamponade. That's why Society of Thoracic Surgery came up with a consensus for this post-cardiotomy arrest situations. The group of experts, including my discussant, Dr. Jonathan Haft, came up with a protocol for patients suffering from that condition. They divided them into 3 rhythm groups, and while they were receiving BLS and ACLS, high quality obviously, they were being prepared for emergency sternotomy. They also recommended that there is a better strategy for organizing the room setup for this very complex situation in order to assign roles in better fashion. When you look to the right lower corner of this picture, you will see this very mysterious 2-person team consisting of people getting ready to roll, do sternotomy, and fix all the bleeding concerns. The weak point of the strategy was prolonged interruptions of CPR, because the chest cannot be compressed when the sternotomy is performed. So the group proposed abdominal compressions in the meantime. I'm assuming that this is what this would look like. After reviewing the available data at that time, which was 2017, they concluded that abdominal-only resuscitation theoretically has the potential to provide systemic perfusion while the emergent sternotomy is being performed. As I was preparing for this talk and doing literature search, I ran into another consensus statement from 2009 from Europe, which was 8 years prior to the one that we just looked at. And guess what I found? I found the same algorithm for patients suffering from post-cardiotomy arrest, same recommendation for the room setup, same recommendation and statement regarding abdominal-only resuscitation based on the same data available, or actually lack of it. But let's focus on the sternotomy team. Is there any way we can train people to do emergent resternotomy? We definitely can provide low-fidelity training for people to do emergent resternotomy. Unfortunately, high-fidelity training to perform surgery is not really available. It's a little bit like taking a person, explaining the surgery, sending them to OR, and hoping that they will do a good job operating. But some groups actually try to tackle it. And they train the ICU staff in emergent resternotomy procedures. For example, this group published a paper on this process. Just like the very name of the journal, I was very curious how they did it. So they organized the equipment. They got the trays from the operating room. They trained the ICU staff how to hand off equipment in sterile fashion. They provided a model of human chest, and subsequently taught people how to defibrillate directly and how to do direct cardiac massage. The measurement of the success of the training was comfort and self-perception of ICU staff in terms of proficiency in performing emergent resternotomy. The only question is, does it really translate into clinical scenarios, and does it ultimately improve patient survival? Big challenge of training emergency resternotomy is increasing number of sternotomy closure devices nowadays. It's really not just wires anymore. Rigid fixation is becoming standard of care in majority of practices around the country. Enhanced recovery after surgery guidelines recommend rigid fixation in all sternotomy patients. There's two implications of that. The sternum is really strong, and it tolerates deep, high-quality CPR, and more systems means more ways of re-entering the chest. For example, when you look at this system that is very commonly used around the country, what do you do with it? Do you cut it here? Do you cut it here or there? Or do you remove all the screws? What about this one, also very commonly used? Do you cut the plate in this area, that area, or do you cut the band, or do you remove all the screws? It is very difficult to provide high-fidelity training for those reopenings of the chest closed with those devices because it's expensive and it is commonly used. There are many. Let's focus on ECPR. What is ECPR? It's an emergent VA ECMO cannulation in cardiac arrest, so extracorporeal life support. There's many reasons why it's better, but the main reason, in my opinion, why it's better is because there's no need for a cardiac surgeon. Even more so, there is no need for any surgeon. Shock teams exist in multiple hospitals and programs around the country. We do not have sternotomy teams. Many patients, including where I work, are fast-tracked between hours 6 to 18 to leave the ICU and go to the step-down or floor. I don't think this is a good idea to perform emergent resternotomy on the floor. Shock teams have robust member availability. Any mid-level or upper-level provider can become part of the shock team. We can pull any cannulators and train them from majority of specialties that we work with: cardiologists, interventionists, cardiac surgeons, vascular surgeons, and intensivists. after obviously appropriate training. Systemic solutions for ECPR programs have been around for years. Cath lab-based ECPR programs have been around for a long time and are functioning well. ECPR is basically a single operator procedure with any team member naturally trained for assisting it. It is nothing else than large ball cell division technique like line placement. We can train team members in both low fidelity and high fidelity setups. One of the most recent papers reviewing ECPR protocols that looked at 1,723 patients concluded that one of the most important factors affecting favorable neurological survival is time from cardiac arrest to triggering the ECPR protocol. If the cardiac arrest was recognized as refractory at 10 minutes, neurological result was favorable. So again, timing was crucial. Also, Seldinger technique was found, percutaneous Seldinger technique was found to be associated with less complications and shorter time to flow. ECPR allows us for uninterrupted, high-quality chest compressions with very familiar to us Lucas device that was found in studies to have same safety profile to manual CPR and causes no more internal injuries and no more lethal injuries. We know that it provides better coronary and brain perfusion, and we can, in the meantime, resuscitate, defibrillate, and cannulate the patient. All of us are familiar with this picture. Patient receiving high-quality mechanical chest compressions while being cannulated in the cath lab by trained staff. The main difference between those two pictures is not only the fact that the one on the right is much simpler, but the fact that the one on the right is an actual picture of real-life scenario ECPR performed in cath lab, whereas the one on the left is an old cartoon of what we would like to have, but is very difficult, if not impossible, to implement in real life. As I was looking through the literature, I thought, I'm going to say there is no way you can find YouTube video of emergent resternotomy. But then I thought, well, I better check it because Dr. Haft's going to look for it for sure. And to my surprise, I did find one, and I was very impressed. However, as I was looking a little closer, I realized that the operator is cutting perfectly exposed sternal wires in a plastic dummy in a situation that looks like sternal non-union. So again, low fidelity training. One may ask, what about the bleeding and tamponade? How are we going to address it with tamponade? How are we going to address it with ECPR? Bleeding and tamponade, one of the most common reasons for post-cardiotomy arrest. We know the heart is being compressed and collapsed. And the question is, how do we drain SVC and right atrium when tamponade happens with multi-stage venous cannula? We know from the studies, and this is one of the most recent ones, that when we look at the multi-stage venous cannulas and we divide them in zones where the tip of the cannula represents SVC and right atrial area, and then we study the flow through this cannula with MRI and then compute the flow characteristics, we realize that only about 10% of the flow comes from the tip of the cannula that normally sits in the SVC and right atrial area, and 90% comes from below. So patients with severe tamponade can be saved with ECMO as long as they're properly cannulated and resuscitated, and because VA ECMO bypasses the chest, really. ECPR in post-cardiotomy arrest is a step, not a stop, and the surgery may be needed, but first patient needs to be resuscitated. So first, we have to cannulate, resuscitate, and then operate if there is a need for it. With all this robust data and common sense, Dr. Jonathan Haft and his colleagues updated the consensus and made ECPR in post-cardiotomy arrest Class 2A recommendation. So answering the question, do we operate or resuscitate in post-cardiotomy arrest? We resuscitate. Thank you so much.
Yeah, So this is like the 5th year that I've done a debate at ELSO, and I think the reason they keep picking me for the debate is because I don't have any pride left. And so I'm willing to take a beating over and over again. And once again today, I'm going to be taking a beating. So anyways, just some boring slides here that you've heard before. You know, this is a big problem, right? Hundreds and hundreds of thousands of cardiac surgeries are done just in the US alone. Cardiac arrest is not completely uncommon. Somewhere between 1% and 5% of these people will have an arrest, and there are huge implications for this, right? So survival of in-hospital cardiac arrest has not changed, right? Over time, it's still like 20% survival without change. So really a big implication of an arrest after surgery. Now, survival after cardiac arrest from cardiac surgery is actually much better, 50%. You may say, well, that's pretty good, right? But keep this in the perspective that the expected outcomes of CABG is 99% survival, right? That's what the patient thinks when they signed up. That's what the referring doc thinks when they send the patient to you. That's what your hospital administrators are expecting, and importantly, that's what your payers and your government regulators are expecting. So suddenly that 50% survival is not so good. So obviously it's a catastrophe for your patients, for the families, but it's also a big black eye for your own institution, right? Your SDS star rating, everybody's, nipping at your heels for that, your public reporting, it is a big deal. And so cardiac arrest after cardiac surgery is something that we really need to push the boundaries for. So it's a big deal, and we're going to try to tackle it. How you doing? I'm Ted Lasso. It's nice to be here. Y'all doing good? Yeah. Well, listen, we're going to try to solve this problem, and we're going to solve it together. The key is the we, and the key is unity, right? Working together. Now, my opponent has proposed that he's going to solve this problem through individual accomplishment, right? He wants to be the hero, right? Come on in and put this patient on ECMO. Now, I've dealt with players like this before, right? I know how to roll them into the fold and get them to be part of our team. Now, speaking of teams, there is the STS, right? The Society of Thoracic Surgeons. This is the preeminent organization for cardiac surgery in the United States. And they put together a team. They call it the Task Force on Resuscitation After Cardiac Surgery. And this team included people from all the nations of the world. It included people from different backgrounds and different perspectives. And as my opponent mentioned, one of these people that was on that team is this particularly charming, I would say very handsome guy right there. He needs a little more facial hair, but anyways, he's part of that team. So let's dive into what that team actually did, right? So this team reviewed thousands and thousands of publications that were up to date. And we went through the Delphi process. The Delphi process, any of you have been involved in, is a very painful process. But basically, you dissect out every recommendation, you debate it, and you don't make the recommendation unless you get that 75% consensus. So it really was a community of people that were making these recommendations using up-to-date literature that was available at the time. Now, why do we make these recommendations? Recognizing that cardiac surgery patients are different. All the practices in the hospital about treatment of cardiac arrest are different for cardiac surgery patients, and we're going to go why. So again, using American Heart Association guidelines for cardiac surgery patients for protocols that probably work better for a different population may not be appropriate. So why are they different? The sternotomy. It is a big deal. It has implications on the effectiveness and potentially the safety of external cardiac massage. In addition, the reasons they arrest are different than the rest of the population, and they're very, very reversible, right? You get VFib from pacemaker-mediated issues, ischemia issues, electrolyte issues, all of which are potentially reversible. Tamponade bleeding, there's only one solution for that problem, right? So in this publication from the group at Papworth, they found that almost all of their patients that had cardiac arrest after cardiac surgery, tamponade and VF, right? They also found that the vast majority of these patients had their arrest within the first 3 days. That has big implications. And importantly, they found the likelihood of survival was much higher if the chest was open within 10 minutes. The majority of these patients that arrest, again, the vast majority will be in your ICU. And the implications of that are rapid identification. These patients are continuously monitored. There's eyeballs on these patients at all times. And so usually within 10 seconds, you recognize that this patient has a cardiac arrest. And you have the infrastructure and the trained personnel to be able to address it using the CALS protocol that we recommend. One of the recommendations is a little bit controversial, is delaying CPR in these patients, delaying it for up to 1 minute if the cause of arrest is VF. And you're going to say, what? You're not going to do CPR in these patients? The fact is that the evidence that supports CPR is entirely for out-of-hospital cardiac arrest. There is no evidence that CPR changes outcome for in-hospital cardiac arrest for VF. What evidence do we have for in-hospital cardiac arrest? Rapid defibrillation. The likelihood of survival basically falls off the cliff after 2 minutes. So our proposal is rapid defibrillation. In addition, we advise against early CPR because of the potential consequences. Anybody in this room do CPR on somebody after cardiac surgery? Right, everybody. And you feel it and you hear it, those wires cracking and those fragments going to naughty places. There are implications and there are publication after publication of what can happen from CPR after cardiac surgery. So these recommendations include 3 successive shocks right away before you start CPR if it can be done within 1 minute of the witnessed arrest. This all comes, again, from looking at hundreds and hundreds of modern papers about the effectiveness, showing that 80% of these people will be defibrillated successfully with the first shock, and still a third of them will be successfully defibrillated on the second shock, and then about 15% on the third and beyond that there's very little likelihood of success. So if you go through 3 shocks and you still have a VF or a pulseless VT, then you're going to go on to the next step, which is open the chest. In addition, most of these patients have pacemakers, so when you have a patient who happens to have asystole or bradycardia, again, the recommendations are delay CPR for up to 1 minute to maximize the output of your external pacemaker. So, of course, some of these patients are going to have an arrest for non-cardiac reasons. There's going to be airway issues like an occluded endotracheal tube. There may be a pneumothorax. And so our guidelines recommend that you jump on these problems before you do CPR and before you open the chest. We heard some great talks from Dr. Elliott about the challenge with doing external cardiac massage and the potential benefit of the Lucas device. Obviously, the work of Dr. Belchlavic is enormous, but it really depends on excellent CPR and often using the Lucas device. There is no data supporting the safety of the Lucas device in recent cardiac surgery patients, and in fact, there is evidence to suggest harm, and our society recommends against using them in the post-cardiotomy setting. So tamponade, one of the most common reasons for cardiac arrest. And oh, by the way, CPR is ineffective. If all the blood is on the outside and no blood's on the inside, you can push all you want, it's not going to work. And the only treatment for it is to drain that blood, open the chest, and within 5 minutes. Now, once you've made the decision that we're going to open the chest, you can do external massage again as you are preparing to open the chest with the goal of getting in within 5 minutes, and the CPR should be targeting a systolic pressure of 60. You were talking about the evidence in the literature. In fact, there is evidence. There's a number of centers that demonstrated improved outcomes. This particular center, once they implemented CALS, they had substantially more survival after cardiac arrest once they did early resternotomy. So the team, we talked about this. We looked at this picture here. It's all about the team. So each of these individuals have an assigned role, and through simulation, all of these people will know exactly what their role is when the cardiac arrest happened. I'll point out here, number 4 is the senior code leader. Senior code leader, that does not mean the oldest person in the room. It definitely does not mean the highest paid person in the room. It just means somebody who is comfortable and qualified to do that, usually not the highest paid person in the room. And then on the bottom here is the resternotomy team. The important thing is that the people assigned to resternotomy, they start preparing before you've made the decision to do resternotomy. As soon as the patient codes, you open up that tray, you put on your gown, you put on your gloves, and you get in those starting blocks and you're ready to go. So benefits of resternotomy obviously are going to be related to tamponade, but in addition, internal cardiac massage is better than external cardiac massage. This has been published over and over and over again in animals and in humans. You get better cardiac output, you get better blood pressure, better coronary perfusion, and more ROSC. So opening the chest gives you the opportunity for internal massage. Now you're going to say, well, it's risky. You know, if you don't know what you're doing, you're going to stick your thumb in the ventricle, you're going to avulse a graft, and yes, all of those things can happen, but you can mitigate those risks with training. And what our group has recommended is identification of the apex, putting your hand over the apex, sliding it back behind the pericardium, and then putting your second hand on top, palm flat, fingers out, 80 to 100 beats a minute. We can teach anybody to do this and to do it safely. In addition, once the chest is open, you can do internal defibrillation. In many cases, it's more effective than external defibrillation. Oh, and then by the way, you can put somebody on ECMO a lot faster if you're in the chest. Every cardiac surgeon in the room will say you can definitely do it faster once you're looking at those structures, particularly in the ICU when you don't have fluoroscopy. More on ECMO. So the ECMO strategy, I would suggest, is harmful because you have qualified people that are doing something that is less effective than the things that they should be doing, like relieving tamponade, like controlling hemorrhage, like doing internal cardiac massage, which is better than external massage, doing internal defibrillation, which is better than external defibrillation. And I would say ECMO strategy is largely unnecessary. Most of these causes are reversible if you follow the algorithm. It's a waste of resources. And then, oh, by the way, the femoral misadventures that don't lie, everybody has them, okay? So let me throw you a bone. There are a few patients in which CALS may not be right, and ECMO may be the better strategy. Somebody who's more than 10 days out from their index operation because they're too stuck to open the chest. Somebody who arrests outside of the ICU. It's true, we've decided not to implement CALS in our own hospital because of the challenge of educating that whole different group of people. Non-sternotomy cardiac surgery, you mentioned it before, you know, the mini mitrals, certainly the catheter-based procedures, there really is no role for opening the chest in that circumstance. And then these plating systems. You said it's common, it's 5%. 5% of all cardiac surgeries use these plating systems here. So is it feasible? Is it feasible for you all to do it? Yes, it's easy. It's one piece of paper. And you're going to say, well, we don't have the equipment in our ICU. Yes, you do. It's 5 things, right? It's a pair of scissors, it's a heavy needle drivers, a wire cutter, a retractor, and tubing. 5 things will save a life, I promise. So can it be implemented widely? This is a paper from a nursing journal demonstrating that in a small community hospital, they were able to disseminate that knowledge and they were able to retain that knowledge amongst their team members despite the infrequency of the event. This is another hospital, a large academic center that implemented the CALS protocol, better outcomes, better failure, reduced failure to rescue. My own hospital, we're very big, but it also means we are very clumsy and resistant to change, but we had a champion, a nurse that said, we need to do this, and we do it every month. The first Monday of every month, this is what we do, and it's a different group of nurses, advanced practice providers, surgeons, faculty surgeons, everybody has to do it every year going through this simulation, and I would still call it a high-fidelity simulation model. Here's one of our fellows who's teaching an advanced practice person how to do the two-handed technique of internal cardiac massage. This is Kara Agerstrand, our venerable program chair.
Oi, get on with it.
Okay. I know I'm over time. So, in summary, it's pretty, I think, presumptuous of me to take on the role of Ted Lasso. And I think people that I work with might suggest that there's a different character in the Ted Lasso series that resonates with my personality a little bit more. So I'm going to channel that person as I go through my summary bullet points here. Make them feel like they've been struck by lightning. Early defibrillation. Tear them apart. Early resternotomy. Trust your teammates. Assign roles and responsibilities during the cardiac arrest. Don't ever settle for fine. Simulation-based education should be the standard for everybody. So thank you very much, and I will celebrate my victory in the usual fashion.
Thank you. Would you like to go ahead?
Yeah, thank you for the amazing and amusing session. I am Dr. Teruya from Texas Children's, Houston. I'm a coagulation physician. So what's the preferred anticoagulant in the setting of ECPR, heparin or bilirubin?
Yeah, I'll take the question. We never use bilirubin, and we many times don't use heparin within the first 24 hours.
So I work at the children's hospital. So the patients may be very small, so the slow flow rate. So I'm not very comfortable not to give anticoagulant for many hours.
I would just say at Boston Children's, our standard is to give a bolus of heparin upon introduction of the aortic cannula. Most of the time that is through the open chest. But yeah, and then oftentimes we'll defer heparinization until the bleeding is abated, which can be, many hours.
Maybe I should say that we are not heparinizing everybody. We are very careful. We always give a very small bolus, and we try to give heparin if possible. But if we have a blood bleeding from endotracheal tube or any signs of intrathoracic bleeding, we are very careful with that.
Scott Silvestri. I want to ask my friend and colleague Jonathan Half a couple questions about this. But first of all, a suggestion. I think Higgins was probably closer than Roy Kent for you, but that's another story. So what about in the transplant population? Or what about populations where fibrillation and tamponade are less likely? And let's say you're an experienced center like Big Blue and you put rescue lines in the groin and you have an amazingly talented ECMO team that can go on in about 2.5 minutes. And would you then change your pretest probability of saying, ECMO versus opening the chest?
So the debate is over, right? I already won the debate? Okay. Yeah, I mean, if you think the problem is pump failure, then it's very different, right? So if you come out of the operating room with a patient with poor function and a lot of drips, you put those lines in the groin so that you're ready to put the patient on ECMO, because opening the chest is not going to help in that situation. They're dying of pump failure. So I think it really does. It's a nuanced sort of thing. But if you look at it from a population perspective, most cardiac surgery is CABG and valve, and most of those people are arresting because of ventricular arrhythmias or because of tamponade, which are fixable problems.
Yeah, but remember your population that you're talking to here is ECMO specialists, right? People who are very facile, familiar, and skilled in these rescue techniques.
Seemingly, I'm unpopular no matter where I go,
Yeah,
Scott.
I got you.
Thank you. Well, I think we could close then by having a vote on the debate. So I think if we'll do a rough hand count, but we'll see if we can restore Jonathan's pride. But for those who think we should be opening the chest post-cardiotomy?
Yes, yes. Get him up, get him up, get him up. Thank you.
And for those who think we should be doing ECPR? I think there was quite a lot of abstainers. I was going to go for the opening the chest, but I'm slightly biased. Thank you very much, and thank you to the panel of 6 speakers. They truly were amazing for a fantastic session. Enjoy the rest of the meeting.